Being specific with rheumatology. Hello there, rheumatology fans. Rheumatology is a specialism that covers a hugely broad set of conditions, within each a hugely broad set of presentations, which of course occur in individuals who bring with them their own circumstances and quirks. For MSK therapists, these rheumatology conditions are masqueraders, conditions which look a lot like something more common. These are, in my opinion, red flag conditions, while undiagnosed, and need referring out of MSK to rheumatology departments. As such, I get requests for courses to upskill therapists to recognise, investigate and refer these patients, especially in light of the increased numbers of first contact practitioners. As MSK therapists, how accurate can we be? Maybe, or more interestingly, how accurate should we try to be? Accuracy is important, and I think we should be as accurate as we can be at all times, for the sake of people's understanding and journey. It can also help with pathway management. Some locations have specific spinal clinics, early inflammatory arthritis clinics, and connective tissue disorder clinics. This can all work against us, though. Imagine a patient with bilateral hand pain. We think this is rheumatoid arthritis. Not a terrible assumption. We run bloods and refer to an EIA clinic, early inflammatory arthritis. But the bloods come back equivocal. CRP20, ESR30, rheumatoid factor negative. This referral is quite possibly going to be rejected. What if we were more accurate in the subjective history, and we realised the person has a history of psoriasis, which we know is more likely to come back with rheumatoid factor negative? A referral of suspected psoriatic arthritis fits the pattern better, and then may be less likely rejected. This is a challenge, and one of the issues is there is no black and white answers. If you spend any time in rheumatology department, this continues as an evolving picture or diagnosis over time. It's absolutely mad to think that MSK therapists would be expected to be highly accurate in these diagnoses when sometimes consultant rheumatologists struggle. What can we therefore do to mitigate pathway issues, yet avoid being drawn into being too specific where it's easy to miss a subtle yet important diagnostic detail? Understanding your own limitations and the local policies is a really good place to start. So where is your ability level with regards to understanding the relevant differences of rheumatology diagnoses and the interplay between comorbid conditions? This might vary between diagnoses as well. If you specialise in spines or feet, you might be a lot more confident with regards to some conditions compared to others, seeing them more often or understanding the differential diagnosis pattern more deeply. Where do you sit in the patient's pathway? All sorts of roles have different responsibilities. If you are working in a predominantly rehabilitation role, it might be that you need to recognise an inflammatory disorder and direct it to another clinician, i.e. an APP, ESP role. It may be that you are responsible for undertaking investigations, specifically referring and accessing the pathways. But what are the local pathways? If your local rheumatology department only has a general referral pathway, there is far less need to be specific at referral. If there are a variety of pathways, which is more likely, then assessing the most appropriate one for the individual is important. Getting them to the right clinician in the most timely manner and with appropriate workups reduces delays to diagnosis and improve experience. What if you get it wrong though? Well, we are all fallible humans, and this is going to happen on occasion. I try to follow this process in rheumatology. 1. Are the presenting symptoms suspicious of inflammatory pathology? 2. Are there associated comorbidities making development of a systemic inflammatory pathology more likely? 3. Is this most likely an enthesitic, synovitic, or connective tissue problem? 4. Can I be more specific at this time? Is it predominantly axial, for example? 5. Which pathway or investigations would be the most appropriate given the answers to the above questions? You can always ask for help, advice, or a second opinion, of course. Sometimes, and I have experienced this a lot, you can be convinced about a presentation, and then by the time the person has seen someone else, the symptoms have changed, new ones have come to light, or they've found out a family history they didn't know before, and it changes the diagnostic outcome. You can't do anything about that. It's difficult because once you have referred on, you often lose the communication loop. But if you do get a letter back that outlines a, in quotes, misdiagnosis, and that seems far too harsh a word in this circumstance, we will get some patients back who look like they have a rheumatology disorder but actually don't. Then go back over your reasoning process, see if there are any gaps, see if anything changed, or if it was just one of those complex cases we all see from time to time.